Fetal positions during birth. Legal disclaimer we put at the beginning of all of our videos. This is for general and educational use only. Content is not intended to substitute for professional legal clinical advice. We strive to keep our information as accurate and timely as possible, but make no promises and guarantees it works for your local unique situation. Course objectives, the students will be able to verbalize why this topic is important. They'll be able to verbalize the understanding of the various birthing positions, and then the common birthing positions to help rotate the baby, pregnancy, and during the labor process, whether the baby's posterior or even being breech. Like, there's different things you can do during pregnancy to help encourage the baby to get in a head down position. The students will be able to help verbalize the risk and benefits of these different labor positions in regards to pregnancy and the birth outcomes. So the importance of this topic, ideally for labor, the baby is in a position with head down, facing the back, anterior presentation, the chin is tucked to the chest, the back of the head is entering the pelvis in a cephalic presentation. Most babies settle in this position around 32-36 weeks, especially if they've had babies before. Other positions that can be a little more complicated when you get breech presentation where the baby's feet are down first versus the head, or a posterior presentation where the baby's head is down but the baby is facing up at the ceiling versus facing mom's rectum. And so you get a larger part of the head, it's a little longer pushing, it may be a challenge of having the baby fit through the birth canal. So there's some things to consider when we're talking about oblique and transverse and breech and the different types of breech and anterior versus posterior vertex presentation. These are a lot of things to consider during pregnancy and prenatal and birth care. So birthing positions has to do with how is the baby directly inside of the mother during pregnancy and when the labor starts. Is the baby sideways, transverse? Is it kind of in a diagonal, which is oblique? Is the baby breech, where its butt or its feet are presenting first? Or is it vertex, where it's head down? And even being vertex, our goal is that the babies will do the cardinal movements of labor and rotate into an optimal position where it's anterior presentation by delivery time. But there may be challenges with asynclitism where the baby's head is just a little bit off to the side, so you're not getting that optimal molding part of the head presenting in the pelvis. Common birthing positions, this has to do with the baby inside the mom's pelvis. So ROA, LOA, these are, an OA would be the anterior occiput. So there's different things that would be optimal. You want baby head down and you want some angle of the baby's face pointing towards the mom's rectum. And then when the baby comes out, you get nice molding, you get the optimal diameter of the least amount of circumference of the baby's head trying to fit through the pelvis. Breech presentations, particularly the more common one of frank breech, is where the butt and then the feet are up by the baby's head. And there's a lot of things to consider with this depending on which direction is the head in the mom's pelvis. When the baby's body delivers, is the head in a posterior or anterior presentation, because that will affect the rotation through the pelvis. So Breech Without Borders has extensive trainings for midwives and healthcare practitioners that want to do vaginal deliveries electively for breech presentation, but it still should be common practice, just like we do postpartum hemorrhage drills and we do newborn resuscitation. Breech delivery should be part of everybody's skills and training, because there are going to be times where the woman comes in with no prenatal care to the hospital, breech presentation close to delivering. You have to have the knowledge and skills to handle those situations. And out of hospital births too. Home birth center, maybe in Leopold's last week, the presentation was head down for this baby and it did a somersault and now she's in labor, and you get to her house, it's her third baby, there's a butt coming out, and you've got to have the knowledge and skills to be able to handle the different variations of breech presentation. So complete breech presentation is the buttocks is first, then comes the hips, and the knees flex. They fold under themselves. Like other breech presentations, it increases the risk of forming the cord getting kinked and coming down alongside the body and being pressed against the head through the cervix when delivering, especially if there's a long pause between the body and the head being delivered with like first-time moms, and you can have some really bad outcomes. If the baby is in an incomplete, complete breech presentation, footling, meaning part foot is out versus just the butt, each one has its challenges with cord and presentation and how to deliver the baby. Prenatally, you can try to do an external cephalic version. We'll talk about that a little bit later. It's typically done by an obstetrician in a labor and delivery unit, so they have available those emergency resources if they try to turn the baby and the cord's short and it pulls and the placenta starts to separate a little bit. You can't force a baby. You try to encourage a baby to get out of that breech presentation. And I always like to stress too, going back to the breech conversation, a lot of these versions could be avoided if women had regular chiropractic care, because many of the breech presentations, the baby wants to be head down, but if the head can't go in the pelvis because it's too narrowed from sitting all the time and the way the angle of the pelvis is, we can avoid a lot of versions and C-sections because of breech presentation if more women had chiropractic care and an optimal opening of the pelvis getting close to delivery time. Transverse lie has to do with the baby being sideways in the uterus. The head won't fit, the butt won't fit. It's the back presenting over the pelvis opening. It's in a C-section. When they go into labor, that baby's not going to fit unless it turns. So at least breech in many situations could be delivered if have to be, but if she's laboring and the baby's oblique and baby's transverse, you're going to have a cord, you're going to have complications. It's just a C-section in the hospital. Footling breech is when the baby's foot is coming down versus the butt, like in Frank, and one or more of the feet may be coming down. You have to definitely worry about the cord and the water being broken, and there's a lot of things to consider with this, and you really... Some midwives that do out-of-hospital births will have the knowledge and skills to do breech and give good informed consent to their clients they're serving, but typically breech deliveries are in the hospital, and many of the obstetricians and doctors nowadays aren't comfortable doing breech because they don't have the skills, the training. They just do a C-section nowadays. Twins, there's a lot of layers with twins. Maybe one baby is head down and one baby is breech, one baby is sideways. You deliver one baby and then the other one repositions and does oblique. So you've got double the presentations to consider and think about when you deliver twin deliveries. There are some midwives do it, but most of the time it's in the hospital setting or just a C-section. There's very few doctors that are comfortable with doing twin and breech deliveries anymore. Side lying, this is like oblique, this is that transverse odd presentation. It's also the same direction of a C-section. You're presenting a shoulder, you're presenting a back, you're presenting a part of the baby that's during labor that's not optimal for a vaginal delivery through the birth canal. So if they're not delivering yet, they're not in labor, you could do a version, you could help encourage, you can do chiropractic, you can do some yoga positions. There's some spinning baby techniques out there that are amazing to help encourage the baby to become head down. There are rare situations that the babies have genetic disorders. They have Down syndrome, they have some anencephaly, they have something where their polar entity can't relate to getting the head down, but that's not as common. It's usually a pelvis or a short cord with a placenta, something underlining going on. So the risk of the different fetal presentations and the birth presentations has to do with how far they are in the pregnancy, if it's 34 weeks versus 40, what presentation it is she a first-time mom versus she's had a baby before, what resources are available, what knowledge and skills do the different care providers have taking care of this mother and baby. So there's a lot of things to think about when you're talking about transverse, oblique, head down, and then thinking anterior versus posterior presentation, ansencytic, there's so many things to consider based on, is this during labor? Is this during pregnancy? How fast were her last labors? Has she had a breech delivery in the past? Has she had a C-section? Is she delivering at home, hospital, birth center? What are the skills of the midwife or the obstetrician taking care of them? What are the resources at the hospital labor and delivery unit that it may be safer to do a C-section versus a vaginal delivery? And maybe you don't have a choice with oblique, transverse, to just do a C-section. So how far along are they in the labor? Has the water broken? Complications with the pregnancy, 1 baby, 2 baby, where's the placenta, how long is the cord, shape of the uterus. She may have a fibroid, she may have a bicornuate uterus that just makes it so the baby sits oblique because it can't get in an optimal position. And so a lot of times ultrasounds are really helpful to determine, because you can't change her anatomy of her uterus. She's always going to have malpresentation babies because of her situation. Maybe her pelvis, no matter how much chiropractic adjustments, she has a narrowed inlet and the baby just can't descend in her pelvis. And there are those situations, but I think too many times we go the direction of the extreme right away versus simple exercise, spinning babies, chiropractic to help encourage the baby to rotate. So there's different things. The medical system uses external cephalic versions, 36 to 38 weeks gestation typically. It's done in the labor and delivery unit under guided ultrasound. The obstetrician with an assistant will try to use their hands on the tummy to rotate the baby, and you want a labor and delivery unit because if there is some complications, the cord gets pulled on, the baby stresses out, the placenta starts to separate a little bit, you need access within minutes to a C-section to help with that baby, because that placenta and cord is their life. There's simple things you can do. Spinning babies has some great yoga positions, hands and knees, butt in the air, get the baby out of the pelvis, warm things, cold things, music, talking to the baby, hip rocking, chiropractic adjustments. But sometimes, especially during labor, when you've got a baby head down and it's asynclitic or posterior presentation, hip rocks and position changes are really, really powerful to optimize the cardinal movements of labor and get the baby in a better head down presentation. Stimulating sounds, encouraging movement, cold things, hot things, light, warmth, voices. I've seen great success that midwives don't typically talk about it, but there's a few that they'll take them to the local community pool and take away gravity, and the midwife will be very gentle on her tummy and help to encourage the baby to move on its own into an optimal position. I don't recommend that because there are risks and you can't monitor the baby closely, but I've seen it done. So there's so many ways to get to the root cause and challenge of why the baby's in an odd presentation. And sometimes you're just in labor and it is what it is. It's engaged. You can't do anything at this point. The water broke. She's contracting. Baby's oblique, transverse. There's not really much you can do at that point besides just getting a C-section and getting baby delivered. So it's definitely the Webster technique, spinning babies, relaxing. Maybe some people have a really tight pelvic tone and the muscles and tension and symphysis pubis, and the pelvic angle is just not optimal for that baby to be head down, because that's the biggest part of the baby. And that's why sometimes the butt will present. So you want to look at the overall situation. Our goal is to get babies head down, get them in optimal positions, and have a vaginal successful delivery where mom and baby are healthy. So as an overall conclusion, there's a lot to think about prenatally and during birth with Leopold's in the baby's position, and ways to get to the root cause of why is baby in an odd position. When you're in labor, you just don't have time, or maybe your choices are limited because of the options and tools that you have available. So we have to think about our skills as midwives and birth professionals. We have to think of the birth setting. We have to think of our clients we're serving, their birth preferences. They really want a breech delivery. They really want a VBAC. They really want to do their twins at home. They have good informed consent. You just need to make sure that you have the resources and tools and the skills to handle those situations that you're anticipating. So our job as midwives is to advocate, educate, handle emergency situations as they come up, be a gateway to collaborate with the bigger healthcare system, and set up the version, set up chiropractic visits, help them with spinning babies at home, schedule that C-section if they're like, yep, the baby's breech, and I understand my choices with a breech presentation, and I'm a first-time mom, I've had a traumatic birth in the past, I just want to schedule a C-section. So we just need to go over the options and provide resources that are within our scope and collaboration models we've set up in the community.